Hi everyone, thank you for joining me today. So today I'm going to be talking about reducing autism misdiagnosis through inclusive diagnostic practices. So first off, let's start by defining neurodevelopmental disorders. These are conditions that can impact the development of a person's nervous system. And they can look in a variety of different ways, but people with different NDDs often struggle with impairments in cognitive and motor functions, as well as their cognition and memory are affected. And some examples of common neurodevelopmental disorders out there include intellectual disabilities, movement disorders, attention deficit disorder, and autism spectrum disorder, which is the one that we're going to be focusing on today. So what is autism spectrum disorder? Well, the name says it, it's a spectrum, meaning that it can look in a variety of different ways across individuals due to its highly complex etiological heterogeneity, which means that there are many genes contributing to the development of this condition. And it can look in a lot of different ways. It's not like every individual with autism meets the same criteria for it because it can look so different. But some common symptomology that individuals with autism often experience include social communication difficulties, repetitive behaviors, sensory issues, as well as restricted interests. And as you can see on this graph on your right, this is showing the autism prevalence rates throughout the years, from the year 2000 all the way to 2022. And if you specifically focus on 2000 and 2022 is about 5 times as high as the autism prevalence rates were in the year 2000. So the diagnoses have been increasing so much throughout the past few years, and researchers say it's not only across one ethnic group, but multiple different ethnic groups. Some of the assessment tools that we have to diagnose a child with autism include the DSM-5, which I'm sure many of you may be familiar with. This is a tool used across all ages. So I can diagnose someone with autism that's 3 years old by using this tool and someone that's 30 years old, for example. And it looks at a lot of different things, including abnormalities in eye contact as well as body language, and deficits with verbal and nonverbal communication, especially when the individual is engaging in any sort of social environment. And it also looks at difficulties adjusting one's behavior to fit into different social contexts. And then we also have what is known as the MCHAT-R, and this one is used with children aged 16 to 30 months old, so little babies, and it looks at social engagement. So for example, is that child interested in interacting with other children? Do they respond when you call them their name? And it also looks at communication cues. So does the child point when they want something, for example? And then it looks at joint attention. So for example, if a caregiver points at something, is that child gonna look in the same direction as the caregiver? And then additionally, it also looks at sensory sensitivity. So maybe the child is sensitive to certain substances or textures, or maybe they just engage in repetitive behavior like hand flapping, for example, is a very common one. The problem right now is that the likelihood of someone being accurately diagnosed with autism varies greatly according to what ethnic group they're a part of. So if you look at this graph, I know it looks very complex, but bear with me. And if you specifically focus on the x-axis, that one is supposed to be looking at the different ethnic groups. So white, Black, and Hispanic individuals. And then the y-axis is looking at the relative likelihood of individuals pertaining to that specific ethnic group of them being accurately diagnosed with autism. White children serve as the baseline, that's why they add up to 100%, and I did want to clarify that because I don't mean by this that they're 100% diagnosed all the time correctly with autism, but they just serve as the baseline, that's why they add up to 100%. And the Black and Hispanic individuals are being compared to them. So as you can see, Black individuals are 15 to 16% less likely to be accurately diagnosed with autism when compared to white children. And with Hispanics, that disparity is even greater. They're 39% less likely to be accurately diagnosed. And you may be thinking, well, maybe this is a prevalence rate kind of thing. Maybe we just don't see autism as much in Black and Hispanic individuals. But researchers say otherwise. Researchers say that there are other factors that are contributing to this disparity. And one of those factors has to do with the idea that these assessment tools that I just talked about do not take into account the fact that normative behavior is defined differently cross-culturally. So for example, in East Asia and Native American cultures, reduced eye contact is seen as a sign of respect. So maybe a child is not looking at you in the eye because that's what they grew up learning, and that's what was considered as normative according to the environment and the culture in which they were raised. In Chinese cultures and Hispanic cultures, pointing is highly frowned upon. I can speak from a Hispanic point of view, pointing was never encouraged, especially in social environments. And then in Japanese culture, interpersonal space is highly valued. But the problem is that all of these, so interpersonal space, pointing, and reduced eye contact, they all serve as symptomology to diagnose a child with autism. And the problem right now is that the assessment tools that I just talked about do not take into account this fact that normative behavior is defined differently cross-culturally. And this is partly due to the fact that those tools were developed in Western contexts, and that's why they do not take into account those cultural differences that children may exhibit. Additionally, there are other factors that are contributing to these disparities, such as stigma, lack of familiarity with NDDs, language barriers, and lack of services, as well as social status, which I'll talk about all of these right now. So let's start with stigma. In some cultures, mental disorders such as depression are seen as signs of weakness. And this goes for anxiety, this goes for ADHD, this goes for autism, all different kinds of neurological disorders. And in some cases, they're even seen as demonic, which is really sad to think about. And there was a study done with Latino moms, and it revealed just how much stigma there is, and you can follow along on the right. If your child behaves in a way that is not socially acceptable or different from what is expected, people are going to say you're not a good parent, that you cannot control your child, and that your child is spoiled. So there is a lot of stigma that comes with having a neurodevelopmental disorder, which in fact also contributes to this disparity that we're seeing as to like who gets an accurate diagnosis or even diagnosed at all. Lack of familiarity with NDDs also plays a role, so many families from culturally and linguistically diverse populations do not have the knowledge that they need to understand what a neurodevelopmental disorder may look like. And sometimes that's because of the stigma. So there's other factors that could contribute to that as well. But yeah, they just have a lower understanding of common pediatric mental health diagnosis, which also in turn adds up to this disparity that we saw in the previous graph. Additionally, language barriers also get in the way. So if you focus your eyes on the graph on the right, and you specifically look at that purple bar over there, the one that says language barriers at the bottom, there was a study done in 2021 by the National Institute of Mental Health, and it revealed that therapy retention rates experienced a 30% drop. And what I mean with retention rates, it means if an individual seeks therapy, how likely it is that that individual is going to come back again to seek more therapy. And for this study, it was specifically done with Spanish-speaking families, and they just didn't feel comfortable with an English-speaking provider, and that's what kept them from coming back again for another visit. And then we also see lack of affordable mental health professionals, especially for those people that live in rural areas. They do not have access to professionals that can help them to diagnose their child and help them thrive from an early age. And also, they just don't have access sometimes because they don't qualify for health insurance, so that makes it even harder for them to be able to afford these kinds of services. And sometimes they do not qualify because of their social status, which leads me to my next point. There's a lot of families, especially right now in the United States, that are immigrants. And these families from culturally and linguistically diverse populations are scared, especially right now with the deportation risks being so high. So they're really afraid to seek services because they're scared that they may be separated from their child. So that's also a factor that makes them more reluctant to want to seek the services that their child needs to thrive. That just delays the diagnosis, and it leads to children being diagnosed later on throughout their lives. So what can we do? Because I've been talking about this a lot, and we know now that we have an issue, but what can we do to help out? Or what has already been done? Well, we have what is known as the ACTS training model, and this is an acceptance and commitment training, and the goal of this is to enhance education in diversity, equity, and inclusion when treating culturally diverse patients. So what this is, in simple words, is that it's a tool, a kind of training that helps providers take a step back and think, okay, is this assessment tool really capturing the full picture for this child? Is this assessment tool really taking into account all of the beautiful qualities that they possess, all of the strengths, and maybe also the things that they can't do as well? Is it according to their cultural background? And if so, okay, are the interventions that I'm providing social-culturally sound for the family? And if not, then maybe I need to take a step back and understand the limitations that come with assessment tools. So it's a really good tool just for providers to not be so rushed to diagnose a child, but take the time to get to know them and take the time to learn about their cultural background. And within this training, they talk about what is known as the Indian Scale of Assessment of Autism. And this assessment is specifically used in India to diagnose Indian children with autism, which is amazing because it does take into account that cultural component, and therefore it leads to more accurate rates of diagnosis amongst Indian children, because it takes the time to understand the Indian culture. But we not only need this in India, we need it all around the world for all different kinds of cultures, because again, we've all been shaped and molded in different ways according to the cultural background in which we were raised. Then additionally, we have what are known as NDBIs, and these are naturalistic developmental behavioral interventions, and they are evidence-based approaches that teach children social communication skills in natural settings. So what this is, in simple words, it's kind of like a parent tutoring. So providers sit down with the family and they work with the family directly rather than working with the child. So they sit down with them and teach them all of the social, cultural, and social communication skills that they could then implement with their child to help them out. And they also give them some tips and tricks that they could use with their child to connect in a more emotional and better way with them. So it's one-on-one, the parents or the caregivers with the provider, and of course these have to be different according to the culture in which they were given at, because we all have different social cultural norms. So Kenya has already started to adapt their NDBIs. They have already started to take a stab at it, and they have incorporated cultural components within that training that parents receive with the provider. For example, on the right you can see they have what is known as Kiamsha Quinoa, which I'm 100% sure I'm pronouncing wrong, but bear with me, I'm sorry. This is a mid-morning tea and snack. So Kenyan families really value that mid-morning tea and snack, so providers actually sit down with the families and have that tea and snack with them because they know how much they value that. And not only that, but there's other examples, and it just helps the family feel safe, feel understood, and feel better equipped to support their child. Because I'm a firm believer that you can give someone a diagnosis, you can give them an intervention, but it's a whole other thing that they take on that intervention and diagnosis and support their child. And for that to happen, the first step is for families to feel comfortable and safe. And this is a great way of doing that. And what's amazing about NDBIs like these is that children do not necessarily need to have had an autism diagnosis before these NDBIs are conducted. And some children have to wait up to 3 years to get an appointment to be diagnosed with autism or get the services that they need. So this is a great way for families to get a head start and help out their child thrive from an early age. And then additionally, we have what is known as It Takes Two to Talk. And it works in the same way as the Kenyan one. The difference with this one is that it was culturally adapted recently in 2025 by Emory University to be used with Hispanic and Latino parents. And what this does is it's a similar NDBI. It works in the same way, but again, it was adapted for Hispanic culture. And the way in which they adapted it includes that they incorporated metaphors and analogies that Hispanic parents really love and resonate with. So one of them is the following, you can see on the right. Acuérdense que vamos pasito a pasito como la canción Despacito con Luis Fonsi, which translates to remember that this is a step-by-step process like the song Despacito with Luis Fonsi. And if you know Hispanics at all, we love Despacito. So incorporating things like this that parents love and caregivers in general not only makes them feel comfortable, but also helps them retain the information that they're learning throughout their training, which is really important for them to actually be able to successfully help out their child in the best way. And I'm actually expected, God willing, in July to start working with Emory University and with these families and conducting NDBIs myself to support them in that journey of connecting emotionally with their child and giving them those, giving parents communication skills that they need so that they can support their child in the best way, which I'm really excited on. But yeah, that is all I have for you. Thank you so much for being here. It means the world. But also, Dr. Davis, thank you so much, my mentor. I wouldn't be standing here without you, and I'm just so grateful for all the lessons you've taught me. And I'm trying not to tear up, but thank you for always believing in me. Thank you.
Thank you so much, Arianna, for another fascinating presentation. Are there questions? Next.
Yeah.
So you mentioned potentially working with these families in the future. Do you have any intentions on carrying this research that you've done over specifically to apply to those families when you get there?
Yes. So the plan right now, I'm going to be, first of all, learning this kind of intervention, right? Because it's a very rigorous training to give out these NDBIs, and there's a lot of factors to it. So I'm going to spend a couple of months learning how to conduct these NDBIs. And then, they still need so much work because, yes, they have been... Emory started to culturally adapt them to be used with Hispanic families, but there are still other elements that we could incorporate, such as, Hispanics really value social gatherings. So maybe parents that are in that NDBI program taking the time to meet up with them, have some sort of social gathering so that they can talk with other families and maybe relate to them and help them through this process of learning the skills that they need to support their children from an early age. So that's a plan, but yeah. Of course. Hi.
Really interesting talk. So you might have said this at the beginning, but those first tests that were developed, was that several decades ago? And there's basically just been a few decades where we've been misdiagnosing
Yes.
children.
Yeah.
And the Indian test, that specific one for Indian children, is that that was fairly recent?
Yes, that one was fairly recent. I think in the past 2 years it was developed, the Indian assessment of autism, because researchers found that there's a lot of differences in Indian culture versus Western context kind of cultures. So that one was developed very recently. And yes, the DSM-5 and the MCHAT-R have been around for a while now. They have been adapted, not culturally, but just to include more autism symptomology throughout the years. So the DSM-5, before that one, there was the DSM-4, the DSM-3. So it has been adapted, but it hasn't, I believe, in a long time, about 10 years, it hasn't been adapted more, the DSM-5. So yes, the Indian scale of assessment, that one's relatively new, and that one incorporates those cultural aspects that the MCHAT-R and DSM-5 don't necessarily incorporate.
Yeah, I mean, it sounds like a lot of the research on these gaps has been fairly recent. So,
Which one? Sorry.
Figuring out that there are these gaps in diagnosis.
Yes.
Doing studies on that.
Oh, absolutely.
That's fairly recent. So this is exciting.
Yeah.
I mean, it's really cool that you're getting into it right now.
Yeah. It is very exciting, and it's a gap that I explored throughout college, and it is recently new. The articles that I looked at, they're from 2020 forward, so all of them are relatively new because this is a topic that people have been talking about as we speak. But yeah, it's relatively new.
I'm going to invite, one more question, and then I'm going to invite your advisor.
What made you want to do this research?
What made me want to do this? I think a lot of different things. I think I've been very blessed to have worked with bilingual neuropsychologists in my college career, and they do take that time to learn about their patients and learn about their cultural background, and they have, I guess, shaped me in the way that they've taught me how to take a step back and think, is this assessment tool really the most qualified to diagnose a child, or do I need to take a step back and learn more about their cultural background and maybe things that we have been missing? For example, one thing that always stuck with me is the fact that these providers that I worked with, sometimes a child doesn't know a word, and because the assessment was translated, but they just don't know the word because they didn't grow up talking with that word or using that word. So sometimes they just don't know that word, and that doesn't necessarily mean that there's some sort of cognitive deficit. They just didn't grow up with it, and the translation does not really adapt to what they heard. Because amongst Hispanics, in Honduras, where I'm from, we say things differently than in Mexico, for example. So there's like a lot of things that are not incorporated within assessments. But yeah, that's what made me want to do this research, just because I've been able to talk with a lot of providers that do really take into account that cultural component with their patients. So yeah. Thank you.
Thank you. Dr. Davis, would you join us up here? And so, Dr. Davis, Dr. Boyette Davis.
Whatever.
Okay, I always say the students are Dr. Davis. Sorry, I'm ruining the moment. Dr. Boyette Davis is going to present Arianna. You can afford to install that she'll wear at graduation. It's up at this moment is being recorded.
I just looked up.
But 4 long years of really excellent work and academic success in the honors program. So thank you, congratulations. And Dr. Davis has a chance to say whatever she would like.
Was moved by being thanked by Arianna for being a part of this, but really it's my honor to be a part of your journey. I mean, it's rare that I have the opportunity to work with someone so gifted, right? Like, there's so much promise ahead of you, and I will forever be grateful that you let me be a part of this with you. Truly embodies everything that we want from an honor student. And from just a student, she is at the heart everything that St. Edward's wants to be and to represent. So I'm so happy for you. You did a wonderful job and I'm so proud. Thank you so much.